Good noon, everybody. Saturday for everybody. Or is it Sunday in Australia? I don't know. I can never keep track of those days. Good. It is officially afternoon. 40 seconds afternoon, I guess, here. Now, some of you may notice on the screen it looks like flickering. And I think it's just, we figure solar flares. Look at this. I'm getting all kinds of pop-ups. I think we're having solar flares or something. Oh, that didn't work. That didn't help. So we have a lot of sunlight. We have artificial light. And now we have flickering light. So as long as you guys don't have a seizure disorder, we're not testing you for that. If you do have a seizure disorder, then you better cover up my face or that part, okay? And just concentrate on the slides. You don't need to see me anyway. You already know what I look like. Okay, so yesterday we finished up with tetralogy of Fallot. We said that was the most common of the cyanotic heart diseases. And yesterday I sort of teased you with tricuspid atresia. Okay, so this naturally follows. I said that tricuspid atresia a lot of times looks and acts like tetralogy of Fallot, but there's a couple of differences that you will need to know as far as on your findings. Okay, so all right. So let's look at tricuspid atresia. Here is your normal heart again to review. Blood from the body enters the right side of the heart, goes to the lungs, comes back from the lungs oxygenated into the left side of the heart and out to the body to do its thing again. With tricuspid atresia, the problem is that the tricuspid valve is the issue, so very little blood makes it into the right ventricle. Therefore, the right ventricle itself is underdeveloped. The only real way that any significant amount of blood comes into the right ventricle with tricuspid atresia is through a small VSD. But as you can see, look, here's a normal right ventricle. Here is the right ventricle that we see in tricuspid atresia. So very little blood gets into the right side of the heart, to the right ventricle. So what happens is the blood that is supposed to go into the right ventricle is like water. It takes the path of least resistance. It goes across a foramen valley, and now it makes its way into the left side of the heart, thereby bypassing the lungs. Okay? So we're having a bypass of the lungs just like with tetralogy of Fallot. Just like with tetralogy of Fallot, there is a single S2. The reason being that very little blood is coming out the pulmonary. The pulmonary artery itself is not atretic or stenotic, but there's very little blood coming out of the pulmonary because there's very little blood getting into the right ventricle. Therefore, the valve that you hear closing is the aortic valve, just like in tetralogy of Fallot. So we have right to left shunting in both of them. We have a single S2 in both of them. Okay? And we'll have cyanosis in both of them. However, when you get the EKG, look what happened. In tetralogy of Fallot, remember, tetralogy of Fallot is right ventricular hypertrophy. With tricuspid atresia, look at the size of the right ventricle. It's very small. So what you have is left ventricular hypertrophy. So tetralogy of Fallot and tricuspid atresia share in common, they share cyanosis, they share a single S2, and right to left shunting. But tetralogy of Fallot has right ventricular hypertrophy, and tricuspid atresia has left ventricular hypertrophy. Huge, huge difference. Okay? All right. On echo, here is a small right ventricle. Look at this big area, this white area here. Okay? That's the atresia of the tricuspid valve. There's a tiny VSD here, and then here's the left ventricle. So once again, you have left ventricular hypertrophy. You have decreased pulmonary blood flow, just like the tetralogy of Fallot, but you have left ventricular hypertrophy. So if we look back at this, keeping the ductus open at least gets some blood to the lungs. So the blood from the left ventricle would come out. If you keep the ductus open, you will have some blood going into the lungs. So initially, you want prostaglandin, at least until you can do some palliative things that would be surgical. So tricuspid atresia really can't wait very long. All right? What they typically do is you keep them on prostaglandin, and then what they would do, let me go back, they would take the blood that comes from the superior vena cava, they take the superior vena cava and hook it up directly to the pulmonary artery. And that way they're bypassing this problem. That's not going to be on the test. It's called a Glenn procedure. Don't worry about it. All right? But initially at birth, you want to keep the ductus open to get some mixing of blood until surgery is done. All right, the next one is Ebstein's anomaly. This is kind of the opposite. With tricuspid atresia, you're going to have a tiny right ventricle. You kind of also do with Ebstein's anomaly, but the problem with Ebstein's anomaly is that the tricuspid valve is displaced downward. So it makes for a bigger atrium. You have an anatomic atrium, but you have a functional atrium because of the downward displacement of the valves. So the right atrium is bigger, and the functioning right ventricle tends to be smaller. Because of that downward displacement, everything is abnormal, and you will get more tricuspid regurgitation. It is associated with lithium use during pregnancy. So, excuse me, I'm waking up. So it is, lithium is a teratogenic drug, and it can lead to an Ebstein's anomaly. So with a severe anomaly, once again, you have a small, relatively small right ventricle, so they'll be very cyanotic. And you will hear the murmur of tricuspid regurgitation. These, again, echo, surgery. Well, wow, okay. Oh, I know what that is. Okay. All right. So here we see again with Ebstein's anomaly, there will be an increased heart size on the chest X-ray, but decreased pulmonary blood flow. And here we see on the echo, this is the normal right atrium. Okay? You would basically, because there's the left atrium, so this would be the right atrium. But look, the valves are way down here. So this becomes the right atrium, and this little area becomes the right ventricle. It's kind of like a tricuspid atresia in a way, as far as where the blood is flowing and bypassing, and therefore prostaglandin is important. But once again, surgery is the definitive therapy. Okay, yesterday I mentioned that transposition of the great arteries was the most common one to present with cyanosis in the first day of life. And so when we think of the anatomy, all they've done is they've switched the vessels. So blood from the right side of the heart goes out the aorta. Okay, that makes no sense. So that blood would go out to the body. Well, it's blood that just returned from the body. Blood from the left ventricle would go back to the lungs because the pulmonary is coming off the left ventricle. So that blood would go back to the lungs to get oxygenated again. Okay, so basically we're talking about two parallel circulations. That's impossible. So somewhere there has to be a connection. Okay. Now in utero we have a ductus and a foramen ovale. When the baby is born, there may be a VSD associated with it. Okay, but we know for sure we have a foramen ovale, but we also know that's going to close. But for sure we also have a ductus arteriosus. So initially you want to start on prostaglandins to keep the ductus open. So these patients will develop cyanosis very quickly and go into heart failure, especially if they don't have a VSD, because that ductus is just not enough. The reason that you hear a single S2 has nothing to do with the valves. It's just the way that the two vessels are aligned. Since they're switched, the way that they're aligned, you really are only hearing the one set of valves closing at the same time. It's just the way that they're aligned. Okay? A VSD would be helpful, actually, at the beginning until you can have a definitive repair. But you know for sure that you have a ductus, so prostaglandin is important. The X-ray finding, so the blood, which way do you think the blood would go in a foramen ovale in a patient with transposition? It would still go towards the lungs because of the decreased pulmonary vascular resistance. So the blood would go to the lungs either way because of decreased pulmonary vascular resistance. The patient with transposition, they describe what's known on X-ray as an egg on a string. I don't know, doesn't look like an egg on a string to me, but that's what they call it. Okay? The echo, of course, is the definitive diagnosis, and here you see the aorta coming out of the right ventricle. Here's the pulmonary coming out of the left ventricle. Okay? And so initially, the string would be up here somewhere. I don't know. It looks like an egg in a sock. The initial treatment is prostaglandin to keep the ductus open so you have some blood flow and mixing into the lungs. You then would do what's known as a balloon atrial septostomy. What you do is the interventional cardiologist can put a catheter through that foramen ovale and then inflate the catheter, give it a pull, and open up the foramen ovale and keep it open. That's but when you rip it, when you do the septostomy, it rips a hole in the atria. So at least there's a permanent communication there, and not just because you can't keep a ductus open forever with prostaglandin. You just can't keep them on it for weeks and weeks and weeks. It just doesn't work that way. So doing the atrial septostomy at least causes some mixing of blood until you do a definitive repair, which is an arterial switch. So you take the two vessels and you move them over. That sounds easy, but it's not that easy because don't forget, what vessels come off the aorta? What really important, all vessels are important. The coronaries, very good. First chocolate for you. Okay, so when you're switching them over, you have to be careful because you might be stretching the coronaries, and that would not be a good thing. All right? So anyway, prostaglandin, septostomy, switch. We've already talked about the truncus arteriosus on several occasions, okay? And so the truncus, I said, remember, the heart is a big tube, and it folds and contorts on itself, and then the top part of the tube divides into two vessels. Well, with a truncus, you have one vessel, and then it splits into two further down. So you're going to have just one valve, so you have a single S2. Now, one thing to remember about a truncus, all truncus also have a VSD associated with it. So you have a lot of mixing going on at the level of the VSD and at the level of the truncus. Okay? So depending on how much mixing, you may or may not have cyanosis. Many times you just go into heart failure because there's just so much blood flowing in different directions, and you may not have cyanosis, but you can still go into heart failure. There will be increased pulmonary blood flow because there's that big link at the beginning of the common vessel. And once again, you can have a wide pulse pressure and bounding pulses. What else did that? Remember yesterday? For some chocolates? Excellent. Especially PDA. Think of PDA first for the test. Okay, Aminata? Think of PDA first for the test when they mention wide pulse pressures and bounding pulses. All right. So here we see the truncus arteriosus before it splits into the pulmonaries. And here we see the echo. Once again, we have one big vessel. Look how wide that is. And then up here, it splits into two different vessels. And there's a VSD down here. So these patients will go into biventricular hypertrophy. But you do want an echocardiogram to make the diagnosis. And they'll eventually require surgery. We also, yesterday, we gave you an overview of all of these yesterday. And total anomalous pulmonary venous return, we said it looks and feels like a left to right shunt. All of the pulmonary veins would go into the inferior vena cava or the superior vena cava. And they're described as supracardiac or infracardiac, whether they go into superior vena cava or inferior vena cava. The problem with that, it's really not a left to right shunt, because what happens is these vessels, to get where they go, they take a very tortuous path, and they are very easily kinked off. And so the blood can't flow forward into the vena cava. The blood backs up into the lungs. It's meeting resistance. It meets resistance from the lungs, backs up into the right ventricle, and then it takes the path of least resistance, shooting across a foramen ovale. Therefore, that blood is bypassing the lungs, and that's why you would get cyanosis. Okay? I have a picture coming up. So, if it's obstructive, which means that's what I just mentioned, that I just described, was the obstructive kind, then they get cyanosis, pulmonary hypertension, shock. If it is not completely obstructive, then you get mixing and left to right shunting, and now you're at risk for Eisenmenger. Okay, they do describe here what's known as the snowman. I'll buy that. I don't buy the egg on a string, but I will take the snowman appearance on chest x-ray. These patients require prostaglandin to at least get a little bit of blood to the lungs, and obviously they require surgery. And hypoplastic left heart. These again are the mixing lesions. Anything that makes the left heart small falls into the bucket of hypoplastic left heart. Once again, we have a normal heart. Here we have a very narrowed aortic arch, which causes increased resistance in utero. I thought I had a picture. What happens with, let me finish. And here we have a very small left heart, period. Atrium and ventricle. Okay? Particularly the left ventricle. With a hypoplastic left heart, it's because in utero there was some obstruction to flow, and because the aorta tends to be small. And so the left ventricle does not develop, because the right ventricle is doing most of the work in utero anyway. So now the right ventricle has to, after birth, still do all of the work, and it fails quickly. This is a very bad heart disease to have, okay? Because you can't build. You cannot build and make that ventricle bigger. And the right ventricle is just not made to pump to the systemic circulation. So these patients go into heart failure, again, in the first day of life. They'll turn blue. They'll go into heart failure quickly. It's just that it's not as common as transposition. Here we see right atrium, right ventricle. Look at how tiny. Look how tiny the left ventricle is. So once again, the echo is the diagnosis, and the patient has to have several heart surgeries. It's done staged to fix the plumbing. You're not going to make a bigger ventricle, but you can fix the way that the veins and arteries drain. Let's get back to the total anomalous pulmonary venous return, Asim. So what do I mean by tortuous? Normally, I'll just use this picture. Normally, the blood from the heart, the blood from the lungs goes, look, there is a pulmonary vein, there is a pulmonary vein, and it'll enter into the left atrium. Here is a pulmonary vein, here is a pulmonary vein entering into the left atrium. Okay? When you have, for example, an infracardiac total anomalous pulmonary venous return, these vessels that normally would come from this lung onto this side, they go like this, then they come down here, then they come over here. That's what I mean by tortuous. Okay? The vessels from this lung, instead of coming over here, now have to go over here and down here. That's what I mean by tortuous. They get crooked. They have to go a different way, and that's how they get kinked off and obstructed. Does that make sense? All right, we did that? Okay. All right. Changed your name. You changed your name on me, so I wouldn't get on you. Now I know. Okay, let's talk about mitral valve prolapse. So mitral valve prolapse is very commonly encountered. Maggie's protecting you. So mitral valve prolapse is a very common finding. Many times it's just there, okay? It's just something that you find when you hear a murmur or when you're working somebody up, you find a mitral valve prolapse. Sometimes Sometimes they can have chest pain or palpitations, but very often it's just another finding and nothing needs to be done. Okay? The echo, it's hard to pick up mitral valve prolapse on an echo even, because the valves, it has all the leaflets, you have to catch it at a certain point. So you don't do anything about it for the most part. You just know it's a finding. All right. So yesterday, somebody talked about endocarditis. We are out of the congenital heart diseases, and we'll talk a little bit other things. So let's talk about this one. A 6-year-old boy has had intermittent fevers for 3 weeks, accompanied by chills. He has a past history of bicuspid aortic valves and recently had dental work. Oh boy, clues everywhere. All right. So here are the common causes of endocarditis in children. Now, I'm not talking about adults. I'm not talking about drug abusers. I'm talking about non-drug abusing children. Okay? Strep viridans and Staph aureus are the common organisms. Now, Staph aureus is the one that we think about when we think about a patient without underlying heart disease. Strep viridans is more commonly seen in patients that have underlying heart disease or have had the dental work. Okay? All right, so many times endocarditis is a cause of prolonged fever. Sometimes we talk about fever of unknown origin. Well, affective endocarditis is a contributor to prolonged fever. Okay? Sometimes you have a patient that all of a sudden develops a murmur, or a patient that had a murmur and now the murmur changes in quality. Think of endocarditis. And of course, we have the classic findings on the skin, which I'm going to show you in a second. Okay? All right, so this is a splinter hemorrhage. See, it says so right there, so it must be. And it's Wikipedia or Wikimedia. All right, so those are splinter hemorrhage. These are things that we call thromboembolic phenomenon. Thromboembolic phenomenon. Ooh, here's more of them. Okay, here's some splinter hemorrhages. These are Osler nodes on the pads of the fingers. Okay, here are some other thromboembolic. These are Janeways. Okay, and here is a vegetation. So the echocardiogram is very helpful in the diagnosis of endocarditis. Those are vegetations. And you need to know your criteria. So they're your Duke's criteria. Major and minor. Major and minor criteria. All right? So the major criteria include a positive blood culture or an echo showing, for example, a vegetation, or blood flow, regurgitant blood flow. Okay? All right. Minor criteria include predisposing condition, like structural heart disease, like having dental work done, things like that. Minor criteria include fever, the thromboembolic phenomenon we just described. Ooh, single blood culture. When I talk about positive blood culture, we're talking about two positive blood cultures. Okay, so now you've got your criteria listed here. if you have a positive blood culture and an echo with any of these findings, you've made the diagnosis. So the blood culture is extremely important. You can have one of these and three of these. Or you can have 5 of these 6. Either way, that is those are the criteria. Okay? So 2 major, 1 major, 3 minor, 5 minor. That's why this table is here. You need to know this. When you are reading the stem of the question, right? As you're reading the stem of the question, you'll be clicking off the criteria. That's why it's there. That's why you better know it. All right. So what's the big deal with infective endocarditis? Is that now you've got lesions. Okay, you've got these vegetations in your heart. So now you basically are getting insufficiency. So you can go into heart failure. The valves are not closing properly, and you can go into heart failure. So what do we do about it? Well, you give them antibiotics for the organism. You'll have a positive blood culture more often than not. Long-term antibiotics, and then you treat the heart failure. All right? And they may actually need surgery because of the valves. You have a bunch of other organisms listed in your notes, but please remember in children, strep viridans and staph aureus. Okay, this is also super duper high yield. This is also super duper high yield. Is who gets prophylaxis. This has changed over the years. We used to give it to a lot more people, and we found out it's not really, you don't need to. Okay, the studies are showing us we don't need to. So you have them listed for you here. Okay? And who gets prophylaxis? Okay? If you're going to do dental procedures of this type on a patient, so these should actually be under this. Okay? If you're going to do a dental procedure, and really big-time dental procedure, in someone who has previously had endocarditis, they need prophylaxis. Or if the patient has had unrepaired congenital heart disease, okay? Or, yeah, it's on page 124, JT, 124, 125. 124, the very last line in 124 says prophylaxis for. And then the actual prophylaxis, the indications are on 125. You just kind of got lost in the page break. Okay? So if you're having a dental procedure and you've had a prior history of endocarditis, you get prophylaxis. Or if you're having a dental procedure and you have had unrepaired or incompletely repaired cyanotic heart disease, so they haven't finished, you get prophylaxis. Or you had a heart transplant with a lesion on the valve, so your new heart has a lesion, you get prophylaxis. And the drug of choice is amoxicillin. Now, what we'll do is we will leave this up during the break. Okay? We'll leave this up during the break, and it explains it. Or you can go to the American Heart Association website, and it's there too. So, These are people who are at high risk for infective endocarditis. People who have a prosthetic valve. Or people who have some kind of prosthetic material for valve repair. Or if you've had prior infective endocarditis. I'm just repeating what we just said. Okay? When we talk about heart disease, we talk about people who have cyanotic heart disease that's not completely repaired, or if they've had completely repaired heart disease, it's been less than 6 months since the repair. If they used, you remember yesterday we talked about a VSD, and somebody asked, what do you do? And I said you do a patch. So let's say you had a patch closure of a VSD, and it's been less than 6 months since that patch closure. You then require prophylaxis. After 6 months, you don't, because you've had overgrowth of tissue, and it's not a big deal. Okay? But maybe you've had a patch, and the patch is still kind of leaky down here. Then you would require prophylaxis. Or, like I said earlier, if you have received a heart, but now you have a valvulopathy in that new heart, then you would require prophylaxis. Okay? We'll put this back up on the break. No, you don't. The prophylaxis is when you have a procedure. This is the table that you need. These are the kind of patients that require prophylaxis. These are the patients that require prophylaxis. The prophylaxis is when they have a dental procedure that requires really mucking around with the gingiva. Okay? When you're going to have if you're going to have your teeth cleaned, it's probably not a big deal. But if you're having a major procedure, yes, remember the prior slide, JT? Look. Amoxicillin is the drug of choice. There you go. Now, see, dental procedures with manipulation of gingival tissue or perforation of oral mucosa. That's when you do, and a history of this, you require prophylaxis. All right? You're welcome. You should have said sheshe, right? You should have said sheshe. That's right. And I would have said bukachet. Had you said sheshe to me, I would have said bukachet. Bukachi. Bukachi. That's right. Bukachi. All right. So these are the people that would need it. If they're having something done that we just described. All right. A body piercing is not an indication for prophylaxis. Okay, so body piercings and tattoos, don't worry about it. Just in case. Just in case. Okay. A 6-year-old girl complains of severe joint pain in her elbows and wrists. She has had fever for the past 4 days. Past history reveals a sore throat 1 month ago. Physical exam is remarkable for swollen, painful joints and a heart murmur. Laboratory tests show an elevated SED rate and a high anti-streptolysin titer. What's your first clue? There we go. Jeremiah, you're so fast there. Chocolates, the age. Very good, Jedis. Very good. All right. Remember, yesterday we talked about strep throat, and we said a common age range for strep is 5 to 10, 5 to 15 years of age. We also said that a common complication of strep throat, which is why we treat patients for strep throat, would be rheumatic fever. We talked about retropharyngeal abscess and peritonsillar abscess, right? Those are complications. But we also mentioned rheumatic fever. So it's not a surprise that if strep throat is commonly seen between 5 to 10, 5 to 15 years of age, that rheumatic fever is commonly seen in the same age category. All right, very good. So we're reading and we say, okay, that's a common age, and now we look at joint pain. What's another word for joint pain? Arthralgia. Okay, we'll put that in our little file. Fever. Sore throat a month ago. Swollen, painful joints. That's no longer arthralgia. That's now called arthritis. Elevated ASO. So now what we're looking at is we are looking at for major criteria and minor criteria. Just like we did with the Duke's criteria for endocarditis, we're looking at major and minor criteria for rheumatic fever. So, you need to know your criteria. It is caused by group A beta hemolytic strep, the same ones that can cause strep throat. Now, not every group A beta hemolytic strep is cardiotoxic or nephrogenic. Not everybody that gets strep throat and does not get treated will go on to develop all these complications of glomerulonephritis or strep or rheumatic fever. Not everybody does. Only people that are infected with a specific strains that are either cardiotoxic or nephrogenic will get, and are not treated, will get rheumatic fever. Okay? Only certain strains. However, we don't check for those strains. We just automatically treat those patients. We treat everybody with strep throat, and that way we don't have to worry about what strain they do or don't have. Okay? That's why we treat everybody. It is the leading cause of acquired heart disease worldwide. And we see a lot of it still. How do they present? You got to know your Jones criteria. Okay? Very important. And if you have a past history of a strep throat, past evidence. So past evidence of a recent strep throat would be a positive strep screen, a positive rapids test, or a positive throat culture. We said that was the gold standard. Or elevated anti-streptolysin O titers, or even better than that is anti-DNase B antigen. Okay? Now you need, with your Jones criteria, you need 2 major. If you've got that, you have strep throat. Or 1 major and 2 minor. Or if you have chorea. Okay? All right. Plus, so what we mean here is that you use your Jones criteria and evidence of a recent strep infection. And here are, I'm not sure about rheumatic fever and autoimmune disease. I'm not sure about that. Here are your Jones criteria, and that makes a nice mnemonic. Jones criteria makes a nice mnemonic. Okay, the J stands for, these are major criteria. The J stands for joints, meaning arthritis. The O stands for carditis. Well, there's not even an O in carditis. However, if you play with the O, look, it looks like a heart. Oh, isn't that sweet? So that's carditis. The N is subcutaneous nodules. The E is the rash of erythema marginatum. And S is Sydenham's chorea. So if you have two of these, when you're reading the stem of the question, if you have two of these, go ahead. This patient has rheumatic fever. More often than not, on the exam, they won't give you two major. But if you have two major, you have it. One major and two minor plus evidence of a recent strep infection, you have it. Or Sydenham's chorea by itself plus evidence of a recent strep infection, you have it. Okay? Another rule to remember, another little pearl for you guys. If arthritis is one of the major criteria, so they're talking about pain and swelling, then you cannot use arthralgia as a minor criteria. Okay? So if arthritis is present, you cannot use arthralgia. Okay, that's double dipping. That's not socially acceptable. All right? So here are the criteria again, just like in your notes, major and minor criteria. Like I said, the best test, and if you have a positive culture, but to look back for evidence of previous infection, the anti-DNase B antigen is better than ASO. What do we do once we make the diagnosis? You give them antibiotics. Why? They already had the disease. That's so that they don't spread that strain to anybody else. So you still give penicillin so they don't give it to anybody else. The carditis can be treated with aspirin. If they have Sydenham's chorea, you can use phenobarbital. Now, the aspirin is recommended if they have carditis and arthritis, but no heart failure, without heart failure. Okay? Correct. The antibiotics all they do is they help you not spread it to anybody else. That's all. Now, usually if the pain isn't too bad, you don't even need to give anything. All right? But you can give aspirin if they have carditis and arthritis without heart failure. Complications include valvular disease, and these are in order. These are in order. Mitral valve is the most commonly affected valve with rheumatic fever. And you prevent by, well, first of all, you prevent by treating strep throat. Okay? You would prevent by treating strep throat. The drug of choice for prophylaxis is penicillin. They get it once a month. Okay, well, that was it. That was it. All right. Obstructive cardiomyopathies. Now, you can see this more in adults or in older children. So, many times, you will be reading a history of an adolescent. So if you look in page If you look in page 126, Sam, it says, if there is carditis, you do this antibiotic prophylaxis monthly into adulthood. If there is carditis. Okay? And it tells you there how long. Okay? It tells you for how many years. So look at page 126 to answer that question. It's actually easier to come in once a month. For many patients, it's easier to come in once a month for a shot than it is to take pills every day. It's very hard to take a medicine every day, 2 to 4 times a day. All right. Let's finish up this chapter and then we'll take a break. So, hypertrophic cardiomyopathy is many times you'll see this in an older child. You might hear about an adolescent that just dies. Okay? So, for example, about 3 years ago, 2 years ago, there was a story of he was a high school basketball player, and he just made the winning baskets. And when they won that game, they went on. They were eligible to play in the state championship final game. Well, during the celebration, right after the game, the child just fell over, and he died. Sudden cardiac death. So sudden cardiac death in an athlete. Think of this: hypertrophic obstructive cardiomyopathy. Okay, I'll show you pictures in a second of a big heart. Okay, so patients can present with exertional dyspnea, palpitations, or just sudden death. Okay? You can hear a murmur. Here is, look at the size of the septum. Whoa. Hypertrophic cardiomyopathy. Look at the size, the whole left ventricle is hypertrophic, but look at the septum. So, these patients should not play strenuous sports. And then these patients are placed on beta blockers. You do not want them on diuretics to dehydrate them and make things even worse. Yeah, this is big time. Okay. Some professional athletes have died from this too. Sometimes actually years after they've competed. All right. Pericarditis, accumulation into space. The most common cause will be Coxsackie virus, although connective tissue disease, autoimmune diseases can also cause effusion, basically. No, beta block, they'll be placed on beta block, not just during symptoms. If you're diagnosed with obstructive cardiomyopathy, you will go on beta blockers probably, not just when you have symptoms. Okay, so look for viral causes or also collagen vascular diseases. This is not as high yield in kids, but it doesn't hurt to know it because some of this will apply to adults. How do they present? Pain, precordial pain. It's worse by laying down, classically, and relieved by leaning forward or sitting up. It's all gravity. And they can have just non-specific findings. Sometimes also abdominal pain. Now, it's referred pain or maybe the liver. And always, this is a huge one, the friction rub. The diagnosis, does this look like a water bottle? These guys, these radiologists. Get an echo. Now, an EKG and chest X-ray are the first things you do. But get an echo and look. Look at the space. That's the pericardial fluid right there. Wow. All right. And then lastly, hypertension. Now, hypertension, the pearl I want you to have here is the younger, several pearls. The younger the patient, you should think of renal causes. If you have a patient who is, 17 or 18 years old, who's overweight with a family history of hypertension, and this child has hypertension, it's most likely essential. But the younger they are, think of renal associations. That's a huge clue. Another pearl would be that just because you get a blood pressure that's high once doesn't mean you have hypertension. So in this scenario, you'll see that they'll repeat it. Okay? When I go to the doctor, my blood pressure is a little high because I know I'm going to get a rectal exam at the end of the day, and my blood pressure goes up. Okay? Same thing with children. They kind of so there's that white coat syndrome. So this girl is 5 years old. The blood pressure is above the 95th percentile. The rest of her examination is normal. But then they repeated it over several measurements, and it's still high. Okay? On the exam, they'll most likely say above the 95th percentile. They do not expect you to know normal blood pressures at each age range. So they'll say it's above the 95th percentile. This girl had a UTI a year ago. CBC is fine, UA is fine now, but look, the BUN is 24, the creatinine is 1.8. So, repeat the blood pressures. The younger the child, think of kidneys. Okay? Now, usually we'll start checking blood pressures at about 3 years of age on a routine basis, unless it's a child with heart problems, and then we check them even younger ages. Always check all the extremities to make sure it's not a coarctation. Okay? And always compare it with normals. On the exam, they will not expect you to know all these different values. So they'll say percentiles. Like I said, it's more essential or primary is more common in adults and older adolescents. So in children, think of other things, especially the kidneys. So always work up the kidneys. The treatment is going to be the same as for adults. Okay, so here are some first things to do. CBC, UA, blood chemistry. So here's where we're going to see your BUN and creatinine. Okay, not everybody needs an EKG and an echo, but that's part of the workup. And not everybody needs a renal ultrasound, but that's part of the workup too. If they're obese, that's your most likely cause. Get them to lose weight. We do not use pills to lose weight in kids. We use exercise and dietary measures. When it comes to managing the high blood pressure, though, we use the same medications that we use for adults. All right, let's do a case. Oh, let's do it right there. Oh. Yesterday, you received a call from the newborn nursery that they were referring you a term infant who was being discharged at 4 days of age. The female newborn's birth weight was 3.3 kilos, and the delivery was by repeat C-section. Findings on exam at discharge were normal. Everything was normal. Heart, her lungs were clear, and no murmurs were noted. Okay? So far, so good. She was breastfeeding without difficulty. Today, her mother calls you to tell you that she is difficult to awaken, pale, and breathing much more rapidly than she was in the nursery. She has had one wet diaper in the last 12 hours. When you meet her in the ED, you note that the infant has cool extremities, weak lower extremity pulses, and lethargy. Don't write the answer. Of the following, the most likely cause of this newborn's condition is aortic coarctation, AV canal, tetralogy of Fallot, transposition, or VSD. Once again, about 2/3 of people are actually clicking. All right, let's stop. The chocolates go to the majority of you who picked coarctation of the aorta. Okay, so the clues here, we can move this out. The clues here were weak lower extremity pulses. Okay? They don't mention cyanosis. So, you know, it's probably not talking about cyanosis. They didn't mention the typical VSD murmur. They didn't talk about S1 or cyanosis with tetralogy Fallot. Okay? So this child, the lower pulses is the big giveaway for coarctation. That's the Greenbrier in Lewisburg, White Sulphur Springs. White Sulphur Springs, West Virginia. It's a beautiful resort. Okay, was I half awake or did we skip a few murmurs? We did a bunch of murmurs yesterday. You must have been asleep yesterday. See you back in 10 minutes. All righty. Here we go some more. So I see that some people want some slides up. During, I guess, the lunch break, whatever that break, when that comes up, we'll let you flip through slides. Okay? So during the lunch break, you can slide through slides. All right, so let's continue. Maybe. Yes. All right. So we kind of talked about cleft lip and palate on the very first day, on Tuesday, when we were doing our physical exam of the newborn. Remember that? So we're just going to mention it briefly here. A cleft lip is an easy diagnosis to make. You just examine the patient, okay? And a cleft lip is also fairly easy to repair. Cleft lip and palate can run in families. It can be part of a syndrome. It can be isolated. The cleft palate, again, the diagnosis will be made clinically. You have to look in the mouth. Take a good look. Now, I showed you a cleft palate earlier in the course when we talked about the Pierre Robin, and you saw that big cleft palate there. Cleft palate can, as opposed to cleft lip is benign, it's a cosmetic thing, but cleft palate can cause some problems. So here is a child with a cleft lip, and that's easy to repair, okay? So the other, oh, you know what? The Bubble Boy movie was on yesterday. I forgot what cable channel it was on, but as I was surfing last night, or it was last night, the Jake Gyllenhaal one was on, okay? It was on. Now, this is what triggered it. Any movies, anybody know? Can you name an actor with a cleft palate? Come on, you movie buffs. Chocolates are involved. Very good, Diamond. Cleft lip, that's what I meant. That's what I meant. Now that I think about it, Rob Pattinson. Yeah, I think you get credit for that too. I haven't really paid. I don't know much about him, but certainly Joaquin Phoenix is one. No way Nicole Kidman. No way Nicole Kidman had a. Well, they all had corrected. If they didn't have it corrected, it would look like this, guys. They'd all be corrected. And they'd look like this. Nicole Kidman, I'm not so sure about that. I don't believe that one. All right. So the cleft lip just requires correction, and usually, and you have it in your, well, you don't, but I'm going to tell you. I thought you had it on the sideline. Okay, so here's your pearl. The cleft lip. Okay, repair of the cleft lip is the rule of 10. Okay, rule of 10. For the routine repair, the patient must be at least 10 weeks of age, 10 pounds of weight, and hemoglobin of 10. So a minimum of 10 weeks old, a minimum 10 pounds weight, and a minimum hemoglobin 10. So you see there around 3 months of age, well, you're usually around 10 pounds with a hemoglobin of 10. So 10 weeks, 10 pounds, 10 hemoglobin, minimum. Then you can go ahead and repair the lip. The palate is usually done at about 1 year of age. Now, the cleft palate does lead to more issues because they can aspirate, they can reflux into the eustachian tubes and be at higher risk for ear infections and therefore hearing problems and therefore speech problems, okay? So the cleft palate is a little more serious, okay? So cleft palate is much more risk of otitis media, hearing, and speech. Like I said, the lip is at 3 months of age. The palate is about 1 year of age. I said 10 weeks, 10 pounds, 10 hemoglobin. The palate, you wait till about a year of age because you get better healing and surgical results. This patient is this patient. Is that amazing? It's the same baby. Nice repair. This was probably a palate too. Nice repair. That's when plastic surgeons are worth their weight, you know, not the other stuff they do for the movie stars. Well, for everybody, for the Kardashians, for the non-celebrity celebrities, right? Yeah, this is where they're really worth their weight in gold. Don't worry about it, Arlene. 10 is easier to remember, and you get better surgical results if you wait until 10. Okay? Now, you can wait longer for lip, but you get better surgical results if you wait until at least those 10s. All right. We don't care about that slide. All right. A 13-month-old child has had a 3-day history of green, watery stools. She has also been vomiting for 1 day. Physical exam reveals a febrile, irritable baby with dry mucous membranes and sunken eyes. So what we're talking about here is a baby that's dehydrated from gastroenteritis. All right, gastroenteritis. Now, gastroenteritis implies vomiting and diarrhea. Here's how we break up diarrhea, okay? Causes. Diarrhea can be acute or chronic. And then we break it up, as always, because we're pediatricians, by ages. In an infant, in a child, and in an adolescent, the most common cause of acute diarrhea is viral gastroenteritis. Now you see that in the child and adolescent, you can also have food poisoning causing diarrhea. Many times with food poisoning, a helpful clue is there's usually a common source, a common outbreak. So when you're reading the question, you'll read about a party, a church picnic, things like that. So with food poisoning, many times there's a common source. When we talk about gastroenteritis, we're usually talking about viruses. We're going to get into the etiologic agents in a minute. In the infant, many times, typically you shouldn't see food poisoning in infants because an infant is less than a year of age, so an infant is being fed baby foods. All right, they're not going to be eating the potato salad at the church picnic. That's why you don't really see food poisoning as a cause of diarrhea in the infant. Although systemic infections, like for example pyelonephritis, febrile UTI, can lead to diarrhea in an infant. And antibiotic use can lead to diarrhea pretty much in anybody, okay, but very typically seen in infants. All right, so you have those listed for you. once again, the clue for food poisoning is that look for a common source, especially for the exam. Especially for the exam. Every once in a while, you get somebody who eats at a restaurant, and they're the only one that gets sick, but they might have eaten something that nobody else ate. So look for a common source for food poisoning. Chronic diarrhea. If you look at infant and children, a common cause is what we call post-infectious lactase deficiency. So, what happens is you're getting over diarrhea, okay? So you had an acute episode of diarrhea for whatever reason, and now you're getting over it, and it turns chronic. And that's because many times you develop a temporary lactase deficiency. What happens is that the diarrhea has removed what's called your brush border of your intestines. And the brush border, excuse me, look what I'm doing to myself, gosh. Must have been up late. The brush border is responsible for the lactase. And so, I do need espresso, I think. So you lose the brush border where the lactase is, so you get a temporary lactase deficiency. Okay? So sometimes a chronic diarrhea can occur after an acute diarrhea due to a lactase deficiency. Now we have other causes here, like a milk or soy intolerance. So many times you'll have a patient that develops, has a lactose intolerance. Even though most people, we get lactose intolerant more so as we get older. But let's say a child, an infant, may not tolerate their formula well. And so many times you switch them, you have an intolerance, and we'll put you on a soy formula. Okay? And the child does well for a couple of days, and then they develop diarrhea again. So now we're discussing a chronic diarrhea again. And many times it's because the child is also is allergic to the soy. So about a third of children who have a milk intolerance, formula intolerance, when you switch them, they're allergic not so much to the carbohydrate, but they also are allergic to the protein. Okay, so a milk or soy intolerance can cause a chronic diarrhea in an infant. This one, chronic diarrhea of infancy. This one is very commonly seen. And what happens is the parents will bring you a child who they say is having multiple watery stools a day. They keep changing diapers, but the baby is acting fine. The baby does not have a fever, the baby is voiding well, the baby is eating well, and the baby is gaining weight. This is what's called chronic diarrhea of infancy. And you have to examine them, and they look fine, they're not dehydrated. You just need to reassure the family that this is very common, really don't know what causes it, but it happens and it'll go away. When we talk about celiac disease, what would you like to know in the question that helps you make the diagnosis of celiac disease? There you go. Very good. Chocolates, gluten-free chocolates for everybody. Gluten-free chocolates. Okay? You want to know about when did this start? Did it start from birth? And they'll usually say no. It started, oh gosh, and look for the diet. Get a good dietary history. Uh-oh, I froze up. Anybody else freeze up? Uh-oh, we're frozen. Just like the song. I'm not going to sing it for you. So should I log out? Should I log out? Okay. I'm going to log out, everybody, and I'm going to come right back in. I'm unfrozen. Let it go. I let it go. I let it go. I came back in and I'm unfrozen. I'm thawed. I'm thawed out. Okay? I can only take that movie once. Sorry. I can only take that movie once. All right. So, for celiac disease, get a dietary history. Very important. Okay. What about cystic? Oh my gosh, Zia. 4 times. Ugh. Once is enough. What about cystic fibrosis? These kids get chronic diarrhea, right? So, what kind of history do we want here? Well, we talked about cystic fibrosis the other day. So, you know, bulky stools, are they gaining weight well? What's their diet like? Do they have a lot of coughing? Do they have a lot of wheezing? Have they had pneumonias, meconium ileus at birth? All these things. Plot their weight. Are there other children in the family or with this? Okay, good. You guys are all over it. Irritable bowel syndrome occurs in children, and irritable bowel syndrome occurs in adolescents, and irritable bowel syndrome occurs for some reason, I don't know why. It occurs sometimes in Kaplan students. Okay? They're going to take, it's the day of the test. It's the day of the test, and they got diarrhea. And then they go take the test, and they come back, the diarrhea is gone. It's gone. And it shouldn't happen with Kaplan students. Right? Because you should be so confident. Okay? It should happen to students that didn't take Kaplan. It should happen to students that went to Brand X review course, that other review course. They should be having diarrhea during the test because they're just not as good as we are. Okay? It should never happen with Kaplan students. We take away the stress. Okay? Absolutely. It's those other guys. Those people go take the test and they're wearing Depends because they're not as prepared as we prepare you. Okay? All right. And celiac disease occurs at any age. It's become such a trend. You know, some people don't pick it up right away. All right. And then there's inflammatory bowel disease. Here's another one. Again, lactose intolerance. We become more lactose intolerant as we get older. And don't forget, especially in adolescent girls, laxative abuse because of eating disorders. All right. That's right. Kaplan does not contribute to irritable bowel syndrome. We are the cure for test-related stress. Okay. So, what about, always worry about infectious causes. Okay? And of course, if kids go to daycare, that's a huge breeding ground. And so maybe the caretakers are not cleaning their hands between patients, or the kids, between kids, who knows? You can also get diarrhea from contaminated food or water, or, like I said, from an extraintestinal infection, like I said, pyelo, or sometimes pneumonia, can lead to diarrhea. Yes, daycare is a microorganism partay. All right. Patients with acute diarrhea can have vomiting associated with it or not. Many times cramping, nausea, fever. You guys know the signs and symptoms. We don't need to spend more time on that. Let's look at the causes. Let's look at the causes. Let's start with the middle. Let's talk about viruses, because actually viruses are the most common infectious cause of diarrhea. And now the norovirus has become number one. Why is norovirus number one? Chocolates, gluten-free chocolates, rotavirus-free chocolates for everybody, because we have a rotavirus vaccine. And so the incident, not that it's, rotavirus is still common, but it's not as common as it used to be because of the vaccine. Norovirus used to be Norwalk virus. That is correct. It's the same virus. I think that every once in a while they just change the name of things or the spelling of things, so you have to buy the new books. That's all. But norovirus is Norwalk virus, yes. So it's still commonly seen where? Oh, JT, you beat me to it. All right, cruise ships. That's right. So it's not just on cruise ships, but cruise ships get a bad rap, It's everywhere. So it's funny because when you go on these cruise ships that you get norovirus or they sink, how do they make it up to you? They give you another free cruise, like you want to go there again. Why would I want to go there and puke and poop my guts out? Oh, I get another free trip, yay. They should give you a free trip to something else, not to another cruise. Right. Okay. So norovirus, you guys already know about cruise ships. Rotavirus, all of these are common causes of acute diarrhea. Also remember that a viral diarrhea, you don't even have to make the diagnosis as far as stool studies, because viral diarrhea is treated supportively. If they're dehydrated, you treat the dehydration. Okay? Another pearl. We do not like to prescribe to children things that make you not have diarrhea. Okay? So all these medicines that are out there to help stop the diarrhea, we do not encourage in children. First of all, these medications that stop diarrhea, thank you, Arlene, let it flow. Chocolate for Arlene for being funny. ROTFL. But I'm not really ROTFL because you can see me, right? All right. So these medications actually do not stop your diarrhea. What they do is they decrease the stool frequency, but the amount of stool will be the same. So instead of having 10 liters of stool, a liter at a time, stool loss, you will have 10 liters of stool, 5 liters at a time, twice a day. We just don't recommend them in children because of the side effects. Keep that in mind, especially for step 3, no extra charge. All right. But you can order enzyme assays, but we don't have to, and there's really no treatment for viral diarrhea other than supportive care. Bacterial causes of diarrhea. That's a whole different ballgame. Okay? Bacterial diarrhea, we do treat some, and we do order stool studies, and the most common would be stool culture. Stool culture is the best test to let you know what kind of bacterial diarrhea you have, except C. difficile. Okay? So C. difficile will be ordered for toxin. You still order a stool study, but it's for toxin. All right? These other guys you can culture. And some of these we treat. For example, we do treat Campylobacter. Campylobacter is many times carried by puppies, and we do treat with erythromycin. E. coli, the invasive E. coli, we usually just let it flow, let it out. Salmonella. All right. We typically do not treat salmonella. Treating salmonella usually results in just prolonging the carrier state. And where does salmonella like to hide? In your body. Very good. Chocolates, gallbladder. Okay? How do we get salmonella? So undercooked chicken, undercooked turkey. Now, if you go hunting, so that what we're talking about is undercooked domestic poultry. Undercooked domestic poultry is where you get salmonella. If you go, it's wild game, that's not salmonella. So if you go hunting for duck, that you can eat it undercooked, no big deal. All right. How else do you get undercooked eggs? So raw eggs. And now when you go to a restaurant and you pull out the menu and it talks about eggs, there's a warning. There's a warning. Okay? So undercooked eggs. Anybody saw the Rocky movie? The first Rocky movie? Okay? I'm sure you've seen it. Now I saw it the very first time it came out. In 1976 when it came out. I was on a date with, wasn't my wife, just a different. I didn't even know my wife then. Okay? And in the movie, he trains by cracking open I don't know how many eggs. And he drinks them. Ugh. Okay? And the next scene, in the next scene, what do you see? He's running. Well, why is he running? That's not training. He's running to the bathroom because he's got salmonella. Okay? So undercooked eggs. And you also get it from like little turtles. Little turtles. Not big turtles. Not the big zoo turtles, but the little turtles. Okay? Now, salmonella, we typically do not treat also because it prolongs the carrier state. However, there are 3 exceptions. There are 3 exceptions. So listen up. These are the 3 times that you treat salmonella. If you are under 3 months of age, you get treated. If it's salmonella typhi, that's positive, you get treated. If it's invasive disease, what does that mean? That not a positive stool culture, that's not invasive disease. Positive CSF culture, positive blood culture, that's invasive disease. Then you would treat. Okay? Less than 3 months of age, salmonella typhi, invasive disease. Then you treat salmonella. Okay? 3 pearls for you right there. Rocky 1, 2, and 3. 3 pearls. All right? It doesn't matter if it's bloody, because salmonella gives you bloody diarrhea anyway. If it's bloody, it doesn't matter. Less than 3 months of age, salmonella typhi, invasive disease. That's when you treat Salmonella. Okay? Shigella and Yersinia, yes, we treat those. Invasive means positive blood culture or positive spinal culture or positive sputum culture. Disseminated is different than invasive. Disseminated would mean that you have all of those positive. Okay? So disseminated means that you have multiple sources that are positive, whereas invasive is what I just said. Okay? All right, so Shigella and Yersinia we treat. C. diff. This is the one that it comes back as a toxin. Toxin. Okay? And then somebody kind of hinted earlier, just a couple of minutes ago, E. coli 0157H7 is the one that is associated with hemolytic uremic syndrome. We do not treat hemolytic uremic syndrome E. coli positives with antibiotics. They have worse outcomes. So if the patient has hemolytic uremic syndrome and is positive for that particular E. coli, treating with antibiotics is a worse prognosis. We leave them alone. Let it go. Okay. Giardia. Now here, when we talk about best tests, we're talking about stool for ova, cysts, and parasites. Here it's stool for culture, except for C. diff, which is stool for toxin. Here it would be stool for enzyme assay. Here it's stool for ova, cysts, and parasites. Here we typically don't have to order it. Here we do treat, so we do order it. So the best test here would be stool for ova, cyst, and parasites. So I've given you dozens of potential questions on this slide alone. The management of acute diarrhea, for the most part, is hydration. Wash your hands so you don't spread it. And then, if you have an agent that warrants treatment, then there will be specific treatment. Okay? Alrighty. So like I said, HUS we don't treat. Salmonella we don't treat except for those exceptions. What about labs? Well, we've kind of already hinted to it, that first slide. If the patient just has what you suspect to be a viral gastroenteritis, don't do any labs. However, if they're describing stools with mucus and blood, then you should probably send stool studies. And you can send it for culture. Okay? So if they're having mucus, blood, things like that in their stool, then you should order some stool studies. Stool cultures are what you're going to order for bacterial enteritis. Like we said, C. diff, you're going to order stool toxin. And the huge clue for C. diff is recent antibiotic use. You don't have to, you can have C. diff without antibiotics, okay? But the classic presentation is prior antibiotic use on the test and in real life, believe me, okay? And obviously, like I said, assays for viruses, but again, we really don't need to do this if you suspect viral. So we went through with the different labs. Okay, here are some associations, and you have page 131. Okay, page 131 has a table like this. In fact, you got a bunch of tables on this chapter. Okay, organism, association, therapy. So I'm not going to read it to you. Again, like I said, the enteropathogenic E. coli typically is just supportive care. The traveler's diarrhea, there used to be a commercial for Pepto-Bismol, I think it was, and it had a family from Mexico here in this country, and they didn't want to drink our water. I thought that was very clever. Okay? So traveler's diarrhea, for the most part, is supportive. Here's a little pearl for you when you're traveling. Not so much for the test, but when you're traveling, if you're not going to drink the water, then don't use the ice cubes either. Okay? If you suspect the water, then don't use the ice cubes, because what are they made of? You know exactly. Okay? Or the vegetables, because that's how they're washed. Okay. And like I said, when we're talking about hemolytic uremic syndrome, you do not want to treat those patients. Here's some more. We already talked about salmonella and how you get it, and I told you what to treat and what not to treat. Beer is okay. You can drink the beer because the process, beer is cooked first. So beer is safe. Tea, if they boiled the water, should be safe. All right. Shigella, I already told you, Shigella can be treated with trimethoprim sulfamethoxazole. Campylobacter is usually self-limited, but treating with erythromycin, if it's bad, treating with erythromycin helps you get better faster. Okay, Yersinia. Puppies also carry Yersinia. Yersinia can cause arthritis. Usually you don't treat unless you're less than 3 months of age or septicemia with Yersinia. We already talked about C. diff, recent antibiotic use, and the treatment is metronidazole or vancomycin. This is a common one. So Staph aureus is the common one to cause the food poisoning. Look for that common source. Look for that common source. It doesn't require treatment. It usually, the onset is within 12 hours of eating the food. Everybody is sick. And then here we got into some parasites. Metronidazole is the drug of choice for entamoeba and giardia. Cryptosporidium usually is a self-limited diarrhea, except in immunocompromised patients, where it can be pretty bad. All right. Let's take 10 minutes. We're getting back into the schedule. We'll start at 1 minute after the hour. I don't want to talk about diarrhea after lunch. It's better to talk about it before lunch. See you back in 10. Alrighty. So we've talked about diarrhea, infectious causes, mentioned all kinds of germs, right, and what to do with them. But here is another cause of diarrhea. It's a malabsorption. Okay? So like I said, diarrhea of infancy is the one that occurs with a baby that's doing fine. So this is the baby that they'll tell you has diarrhea, but is eating well, is voiding well, and gaining weight, and physical exam is normal. The stools are just watery. So it's important to have the parents describe the stool or show it to you. You know, in the unit all the time, here, oh, thank you so much. All right? Some babies with this non-specific diarrhea of infancy is because they're taking in a lot of fruit juice. And so they get kind of like an osmotic diarrhea. But sometimes they don't have a history of anything. Those are the ones that you're going to just reassure. But they're gaining weight well and don't have any other findings. Other forms of malabsorption, then, are problematic. And then we talk about carbohydrate malabsorption and fat malabsorption. And also, we can also have a protein-losing enteropathy. So you can have malabsorption of the common nutrients: carbohydrate, fat, protein. These babies are not thriving, as opposed to the patient with the chronic diarrhea of infancy. They're thriving. Patients with true malabsorptions are not. So, let's now work up this patient. If the patient, like I said, is gaining weight, if it's chronic diarrhea of infancy, nonspecific, you don't need to do any workup at all. None. All right? The first thing in the workup of chronic diarrhea is, like anything else, a history and a physical. When did it start? Does anything make it better? Does anything make it worse? Is there mucus or blood in the stool? Is the baby voiding well? How is the baby's appetite? Let's check a weight. Does this run in the families? Are there any colds? Anything else going along? What does he eat? Okay, try to relate it to foods. When did it start? Oh, when we started such and such a food, okay? Same questions we always ask. And then, after you've done a history and a physical, then you can sit there and formulate your differential diagnosis, and then you can order appropriate tests. If you suspect chronic nonspecific diarrhea of infancy, no specific tests are ordered. Okay? And now we can get to specific tests. Certainly, you need to remember, in any child who is having diarrhea and not gaining weight well, we always have to have the sweat chloride as one of the tests that we may need to order. If they're not gaining weight well with diarrhea, you might see other things or get other history to make you suspicious. They may not have tested positive in the newborn screening because, again, remember, it doesn't cover all the different mutations for cystic fibrosis. Okay. So these are some of the tests you can order, and we're going to break them down based on your suspicion for what type of malabsorption they could have. Sometimes you may need to order them all. stool for pH and reducing substances, stool for fat, stool for blood, stool for leukocytes, stool for culture, stool for C. diff toxins. These are all stool studies that can be ordered. Do you need to order them all? Not necessarily. What about blood studies? CBC. Is the patient having any signs of infection? Is the patient anemic? And that would make you suspicious for blood loss. Okay? A SED rate, because we worry about patients with inflammatory bowel disease. Electrolytes with cystic fibrosis. BUN, creatinine, all these things are blood studies that can be. Do we need to do them all? Not necessarily. And then these are more specific tests. Okay? All right, so we're going to get into this pretty much now. Let's talk first about fat malabsorption. So fat malabsorption can lead to diarrhea and failure to thrive. This sounds like a test question. The most useful screening test is a stool for fat. Screening test, just a spot stool for fat. However, the best test, the gold standard, is a 72-hour collection of stool for fecal fat. So a spot test is the screening test, a 72-hour collection. Have fun with that. Collecting your baby's poop for 3 days and then taking it to the lab. They're going to love you for that, okay, is the gold standard. That's when you suspect that there is a fat malabsorption. Okay? No, for Giardia, it's a stool for ova, cyst, and parasites. For Giardia, you're going to order ova, cyst, and parasite. Okay? This is for fat malabsorption. And then when we think of this, for fat malabsorption, that tells you that there's something wrong with the pancreas. Think of cystic fibrosis. So there's the sweat chloride coming into play. All right? Okay, so that's how you would proceed. So they will describe, once again, bulky, floating stools. You worry about fat malabsorption. Screening test, spot stool. Best test, 72-hour collection. For carbohydrate malabsorption, okay, for carbohydrate malabsorption, then you want to do a screening test, would be a stool for reducing substances. So that this is a brand name. Ouch, I can't believe I have it there. So the best screening test for carbohydrate malabsorption is going to be a stool for reducing substance. Stool for reducing substance. The best test is the breath hydrogen test. So see how I'm giving you first test, best test, first test, best test. This is what Kaplan's all about, boys and girls. Okay, ladies and gentlemen. All right. So, a breath hydrogen test is they give you a carbohydrate load, and then you breathe into this thing, and you're picking up the amount of hydrogen in it. First test, best test. Unfortunately, for protein, there's all bets are off. So for protein losing enteropathy, there's just not a best test. But you can order a spot stool for alpha-1 antitrypsin. The problem with protein is that there's a lot of protein already absorbed in the terminal ileum. So it's just not a best test. Okay? But we can order a alpha-1 antitrypsin level in the stool. So there you have it in table form. I've already mentioned it, and you have it in your text. But if you want to copy that real fast, there you go. First test, best test. For fat, it's a spot stool is first test. For best test would be a 3-day collection. Yay, yay, yay. So much fun. For carbohydrate, first test is a spot stool for reducing substances. Best test, breath hydrogen. For protein, no best test. So just order a stool for alpha-1 antitrypsin levels. All right? Okay. Now we can talk about some other specific malabsorptions, which we've already kind of talked about. So, celiac disease. We've said it multiple times. Look for a history of exposure to gluten. And there you have some items that contain gluten. Now, you don't always get a history of, well, we fed him this and he blew up. All right? But always ask for it, and on the exam, be looking for it. Be looking for a trigger. These patients will present with episodes of sometimes diarrhea, sometimes abdominal distension. I mean, it looks like an acute abdomen. Their bellies are out to here. Obviously, it's painful to palpate them, and it looks like an acute abdomen. That doesn't look like a normal baby's belly, for goodness sakes. So look for diarrhea, episodes of abdominal distension. They can have failure to thrive, vomiting. They feel bad, so they don't eat well. Okay? And this is a permanent disease. All right, here we go. Once again, best, first and best, right? So the best initial test for celiac disease is the anti-tissue transglutaminase. This is a very good screening test when the patients are asymptomatic. Let me just... All right. So this is when you have an asymptomatic patient, whole patient population, you go to a school, okay? This is the best initial test. You do, however, have to check with draw a serum IgA, because some patients have an IgA deficiency, and then you'll have a false negative. So keep that in mind. When you're drawing anti-tissue transglutaminase, you should also get IgA levels, because you can have false negatives if they have IgA deficiency. The best test is a biopsy. The best test is a biopsy. And the treatment of celiac disease is going to be avoidance. Okay, read your labels. Okay, so water is gluten-free. And when you go to the store, you'll be surprised at the things that, of course, they're gluten-free, for goodness sakes. But everybody's getting on the bandwagon. There's a lot of awareness now about gluten enteropathy, and so everybody gets on the bandwagon and they say, this is gluten-free. Well, yeah, it is. Water's gluten-free. But just to be safe, read all your labels. So Ana Maria says soy sauce is not gluten-free. All right, read your labels. And if you read your labels and avoid gluten in the diet, you will be fine. But you have to do it always. Okay? You don't have to go to Whole Foods for this. Go to any store. Okay. In your sidebar, okay, your sidebar on page 132, there are other disease states, okay? Yeah, but you have to pay 3 times as much for their gluten-free. So you have some other things listed for you there that can cause diarrhea, chronic diarrhea, malabsorption. Don't forget, we talked, oh gosh, Tuesday we showed a patient with necrotizing enterocolitis. Remember the preterm baby, bloody stools, okay? I think we talked about it. Yeah. So sometimes those babies have to have a large amount of bowel resected, and then they can develop malabsorption from what's called short gut syndrome. If you don't have, for whatever reason, if you have a lot of bowel resected, you can develop malabsorption because you don't have enough small intestine, and so you don't have enough absorptive capacity. It's called short gut syndrome. Okay. Let's talk now about vomiting. Vomiting. And the first pearl I want to give you is, if you have an infant, anybody under 1 month of age, 28 days, right, an infant, when you're reading your test question and you have an infant that presents with just vomiting, not vomiting and diarrhea, but just vomiting, you automatically should suspect GI obstruction to the top of your list. Any neonate that has just vomiting on the exam, think of some kind of GI obstruction until proven otherwise. You should think that in real life too. Okay? All right, so we're going to talk about some of these things now. Esophageal atresia and TE fistula. We're going to talk about this one and this one. Okay? So, the most common of these is that the upper esophagus ends in a blind pouch, and then you have a distal connection. All right, we'll show you a picture in a minute. So the most common form is going to be esophageal atresia with a distal TE fistula. And these patients will present with vomiting with feeds from birth. Now, the H-type fistula, and I'll show you a picture in a minute. The H-type fistula may not have so much vomiting, but they might have lots of aspiration, and they can present later in life. Many patients, remember we talked about Vacturil, the TE stands for TE fistula, vertebral anomalies, anal atresia, cardiac anomalies, TE fistula, renal anomalies, and limb anomalies. There's your TE fistula. Okay, so once again, let's talk about esophageal atresia and TE fistula. The baby will have vomiting from birth. They may have respiratory problems because they can be aspirating into the lungs. If it's just a TE fistula, then it's not as much vomiting, but they can have a lot of choking and coughing and gagging and pneumonias, but not the vomiting. And here are the types. This is the one that I was talking about. This is the esophageal atresia, and then this is the distal TE fistula. Okay? Esophageal atresia, and this is the most common of them, with a distal TE fistula. And the others are listed there, but this is the one you really, really need to know. This is esophageal atresia by itself. There is no fistula. This is more of the H type. See? So you can see that they're not going to have as much vomiting because the esophagus is okay. But, by golly, they can aspirate into the lungs and get choking, coughing, gagging, and pneumonias. All right, but this is the most common. All right, and here is a beautiful x-ray. Here we see where the dye has just stopped. So this is the esophageal atresia. Many times they will describe the feeding tube, the NG tube, coiled way up here because it can't get through because of the proximal esophageal atresia. Now, what you see here, now there's this patient, if you look at this, it looks like you sit there and go, holy cow, this patient has like complete situs inversus. Look at the heart, there's the liver, and there's the stomach bubble. Except over here, I think it says R. So it's just the way that this is entered. Okay, so let's just say that this patient is normal and not situs inversus, okay? There is your stomach bubble, and there's air in the intestines. This lets you know that there has to be a distal TE fistula, okay? So this x-ray gives you a lot of information. The dye is just sitting there. You will see a feeding tube coiled here and not in the stomach. Yet, there is air in the stomach. So this is esophageal atresia, and the fact that there is air in the stomach and all the way in the belly tells you that there must be a distal TE fistula, or else how did the air get into the stomach? Okay? All right. And all of these require surgical correction. What they do is they go and they cut this off and patch this up, and then they try to connect, do an end-to-end anastomosis of the esophagus. But it all depends on how far you can stretch it to connect it. Okay. Always be suspicious for other anatomical findings, malformations, okay? Because if this didn't come out right, the child may have something else wrong, especially in the chest. So these babies that have TE fistulas, we always work them up with like an echocardiogram, and we work them up with like an MRI of the chest to make sure that they don't have any other anatomic anomalies. Okay, So that would be a vomiting baby with obviously a GI obstruction, esophageal atresia. This baby is not vomiting. Okay, this baby is spitting up a lot. A 4-month-old is admitted with episodes of apnea, which occur 20 to 30 minutes after feeds. That's a big clue. Related to feeds. The mother says the baby has been spitting up since birth. And the baby is at the 5th percentile for weight. That is concerning, okay? Because a lot of babies spit up. A lot of babies spit up. In fact, I always say that you can always tell a new parent. You can always tell when a parent has a new baby because they're always kind of moving back and forth. They're rocking back and forth, even if they don't have a baby with them, because they're just so used to doing that, okay? And they also usually have spit up on their shoulders because a lot of babies spit up, okay? But this is much more significant. Reflux disease, GE reflux disease in babies is commonly seen because the lower esophageal sphincter is not a true sphincter. And so sometimes you develop a little bit more pressure in the stomach than you do in the lower esophagus, and things back up. Okay? It's not a sphincter, a great sphincter per se. So babies tend to regurgitate a bit. Some babies will spit up. Not a big deal. They do that when you're burping them. It's not a big deal. Those babies are not having any episodes of apnea. Those babies are gaining weight well. Leave them alone. Okay? Leave them alone. This is the worrisome baby. The baby that is having apnea. What that tells you is that they're having enough reflux that they may be also aspirating. Okay? So this is the baby that can have coughing and choking. This is the baby that can have wheezes, crackles, because they truly are aspirating. This is the baby that many times will hyperextend. They kind of do that. Okay? It's almost like opistotonic posturing because they have a lot of heartburn and it hurts, but the other thing they're doing is they're trying to not aspirate, and so by hyperextending themselves, they decrease that risk. That's called Sandifer syndrome. Okay? S as in Sam, A, N, D as in diamond, M, S-A-N-D-I-F-E-R. S-A-N-D-I-F-E-R. That's called Sandifer's syndrome. Those are patients that have significant reflux and will have opistotonic posturing. The apnea is because they can have bronchospasm. They can have enough of a bronchospasm to try to prevent aspiration that they can actually have apnea. S as in Sam, A, N as in neonatology, D, I, F, E, R. Okay? There you go. So, the majority of patients with reflux get better in about 1 year to 2 years of age. Why? Because, for one thing, the esophagus gets longer, and so it's harder for things to really reflux significantly, and the sphincter tone gets a little bit better, and so it goes away. Okay? We worry about the one that's not gaining weight well, who's having the coughing and things like that. Okay? Older children and adults, I mean, there's all kinds of commercials for reflux out there, right? Of course. Patients can have spitting up, they can have arching, This is the Sandifer syndrome. They can also have apnea because of the laryngospasm, and they can actually have coughing and wheezing. So, nowadays, we don't do all this stuff, okay? Even though we say that the best test is pH monitoring, we don't do it a lot. Most cases of reflux are just diagnosed clinically. We get a history and a physical, and we don't have to do a lot of testing, okay? If they push you on the exam, how do you do endoscopy in babies? You use a tiny endoscope. Yep, we have them. We have them. So what happens is we have pediatric gastroenterologists, and they have tiny little scopes, and they take a peek and look at that. That's really raw. That's really raw. But you don't have to do that, okay? And again, for the test, if they push you on the test, the best test is pH monitoring. What they do is, we take a pH probe, we put it in the distal third of the esophagus, and we let it run for 12 to 24 hours. And we look at the amount of time that the pH probe reads low pH. The distal esophagus should not have low pH. That means that the patient is refluxing significantly into the lower or distal esophagus. Okay? But nowadays we just don't do that. Nowadays we just do it on H&P. But these are diagnostic modalities, absolutely. So the question is, would you do a gastrografin rather than barium? Probably, but most people don't even do this. The problem with gastrografin is that it's not very thick, and so you can reflux that normally. Barium is actually thicker, and if you're refluxing barium, then you're significantly refluxing. All right. So how do we manage GERD? Usually conservatively. Many times we'll just tell the families to thicken the feeds. So we will tell them to add a tablespoon of cereal to an ounce of formula. We tell them to burp the baby more frequently. We tell them to keep the baby upright for a good 30 minutes after they eat. Don't lay them down. Okay? That's conservative management. Thicken feeds and positioning. We will, however, add ranitidine or H2 blockers or PPIs, one or the other. Okay? If we can also try barrier, but it's fight gravity, H2 blockers, or PPI. Okay? If that doesn't work, then the patient will undergo surgery. And that's in severe extreme cases. That's the baby that sometimes do this not for GERD, but in patients with cerebral palsy. Well, patients with cerebral palsy can many times have GERD, and we'll do a fundoplication, okay? But this is many times, this is a last resort, and it's not that commonly used in a normal baby, okay? Well, grandmas don't know about ranitidine. They just know about gravity, okay? Grandmas go to different medical schools than we do, okay? And some of the things that they teach at Grandma School of Medicine make sense. Most of the things they teach don't. But they know more than we do. All right. Let's continue with vomiting. Because the first thing that a grandmother will ask you is, how many kids do you have? Well, if you no, I only went to medical school. I'm only like $8 million in debt from going to medical school and residency and stuff. And they'll ask you, so how many kids do you have? Right? Right. Okay. A 4-week-old boy has non-bilious projectile vomiting. Physical examination is remarkable for a mass palpated in the abdomen. Okay? So, once again, this is a child that presents with just vomiting. He's 4 weeks old, so he's in that period of a neonate. So that's a huge clue. Remember, we said any neonate that presents with just vomiting, always consider an intestinal obstruction, a GI obstruction, somewhere along the line. Put it at the top of your list. So this child is in the neonate range. This child, well, making it a boy really helps, but then the non-bilious projectile vomiting is another huge clue. Okay? So pyloric stenosis is because that muscle gets hypertrophic. That's why they call it hypertrophic pyloric stenosis. These babies are, this is something that is seen in about 1 in 250 live births. That's pretty common. Okay? 1 in 250 live births. Now, in my hospital, we deliver 2,500 babies a year. That's 10 a year. Okay? About 10 a year. It is much more commonly seen in boys, where it's seen about 1 every 150 births, and much more rare in girls. But doesn't matter. The pylorus, right away at birth, is not hypertrophic. It takes a little bit of time, and that's why usually at around 2 to 4 weeks of age is when you typically see it. Okay? 2 to 4 weeks of age. The non-bilious nature is a huge clue. And you just ask the family, they'll tell you, the baby's been vomiting. For how long? The last week or so. Your next question is, you could ask, is there diarrhea? No. What does it look like? And they'll tell you, it looks like milk. It looks like formula. It looks like whatever he just ate. And then you say, how does it come out? And they'll say, oh, don't say projectile. Don't put words in their mouths. Give open-ended questions. How does it come out? Oh, they'll say it gushes out. It comes out like a hose. It hits the floor. I'm holding him here, and it'll land way over there. Okay? Those are the kind of words that they'll use. That's projectile. Like the exorcist. I always use that term too. It's exorcist vomiting. Okay? How does the baby act afterwards? Oh, he's still hungry. Okay, those are great questions to ask. Open-ended questions. So the fact that it's non-bilious lets you know where the obstruction is. Non-bilious vomiting is at the pylorus or proximal to the pylorus. Bilious vomiting is beyond the pylorus. That's a huge clue. Okay? They can come in. I've had some really dehydrated kids, depending on how long they've been vomiting. The oldest child I've had with it was about 4 months of age. Okay? So it depends on how much vomiting they have, how severe it is when they show up. This olive-shaped thing, I have palpated exactly 2 in like 30 years. So everybody describes it. You can palpate it probably when they're under anesthesia, but it's there. It's another piece of information that's helpful for the exam, but it's not that commonly felt. All right. So when you're reading the test question and they're describing a 3-week-old with non-bilious projectile vomiting, okay, you should be thinking of pyloric stenosis. The best test to diagnose pyloric stenosis is an ultrasound. And here we see a thickened muscle. See it right there from here to here? That's thick. It's also elongated. They will not get into the actual measurements on the exam. But you want to order an ultrasound to evaluate the pylorus. Do not order an upper GI or barium swallow for pyloric stenosis. That can help you, but now you've got junk, you've got dye that you have to suck out. Okay? So the best test is the ultrasound. Okay? Now, there are reports now, there's literature out there that links erythromycin to pyloric stenosis. So we know that it's more common in boys, but there are studies that are showing an association between erythromycin and pyloric stenosis. Usually, this is erythromycin that is given in the first 2 weeks of life. And it's not erythromycin ointment, it's erythromycin by mouth. Just keep that in mind, okay? It's in the first couple of weeks of life by mouth, okay? All right. The treatment of pyloric stenosis is, first of all, rehydrate the patient and correct the electrolytes. That's what you need to do first. And then you can take them to surgery, because then the risk is down. Pyloric stenosis is never a surgical emergency. It's never an emergency. You always rehydrate the patient first. Do not ask your surgeon to come in at 2 in the morning to fix a pyloric stenosis, because they will come in with their scalpel and they will open you up first. Okay? Don't do that. Okay? So, Sam, I'm not sure that the erythromycin causes pyloric stenosis. The literature suggests an association, a higher risk, because there's still plenty of kids out there with pyloric stenosis that did not have erythromycin. Okay? We're going to stay frozen because we're almost finished. Okay? So just a couple of more minutes. So, you can get a question where they present a child with signs and symptoms. The vignette is suspicious for pyloric stenosis, and then what they're going to ask you is, which of the following is consistent, which of the following electrolytes is consistent with pyloric stenosis? That's how they'll ask. They won't say pyloric stenosis, I'm sorry. They'll just say, a 3-week-old baby has non-bilious projectile vomiting. Okay? And ultrasound confirms your suspicions. Which of the following sets of electrolytes is most consistent with your diagnosis? Okay? And then they'll give you 5 sets of electrolytes. Always pick low potassium, low chloride, and high bicarb. Okay? Patients with pyloric stenosis will have a hypokalemic. Oh, I'm back! I'm back! I can see myself again. I unfroze. Good thing I wasn't like picking my nose or something, huh? Woo, that would have been embarrassing. Patients with pyloric stenosis have a hypokalemic, hypochloremic, metabolic alkalosis. So they will give you a bunch of electrolytes. The sodium may be a little bit low. The BUN might be high. That's not an electrolyte. that just might show a dehydrated patient. Okay? So the sodium may be a little low, but absolutely the chloride is low, the bicarb is low, and the bicarb is high, and the potassium is low. Low potassium, low chloride, high bicarb. Okay? You have to look for that. And I was teaching step 3 the other day in New York, and one of the medical students came up to me and he said he came across that same exact question in step 2, and he said, "Doggone it, you guys, this was spot on." He said he had taken the step 2 course and he had taken the test, and he said that the material was spot on. He could see the question, and we had already covered it. Kaplan is the cure for your USMLE woes, okay? And it was I didn't ask him about it. He just came up and volunteered that information, okay? All right. So this is what you need to do first. This is what, like I said, pyloric stenosis is never an emergency. You always treat and rehydrate the patient first, and then electively fix the pyloric stenosis. I think we had a patient with a pH of it was 7 point, I'm going to say 8. I'm sorry, 7.4, 7.5, 7.6. He was 7.68 was his, or 7 point, it was high, okay? And his bicarb was really high. It was a huge metabolic alkalosis. And we had to correct all that first before he could go to surgery, okay? We're going to stop that one, okay? So, that's the kind of question you're going to get. What's your diagnosis? What's the best test? What kind of electrolytes will you see with this patient? Those are the kind of questions you're going to, and what's the treatment? Those are the kind of questions you're going to get with pyloric stenosis, okay? All right. So let's start our break now. We will leave the slides up. I guess this is lunch for somebody. We will leave the slides up for you guys to go and look at all the charts and all the stuff during the break, okay? I think we come back at 4 o'clock. Is that right, Maggie? It's a supposed lunch break. I can rest my voice. Okay, so we'll see you guys at 4 o'clock Eastern time, and we'll finish up this chapter.